Hi everyone, welcome to this little talk, an informal talk about what it's like to be a biomedical scientist, especially this day and age in the current climate of a world pandemic. We're going to talk a little bit about how I got into the profession, really. It will probably be, well, it is going to be haematology and transfusion loaded because that's my speciality. And that's what I've, done all these years. But we'll also dip onto some of the others, I call them the otherologies, like virology or microbiology, etc., just to give you an insight really on what kind of things they do. Like, what are you going to be doing if you continue with this career as a biomedical scientist? And then we'll have a little chat about how to actually get your foot in the door, because my heart absolutely goes out to you guys at the moment. Like, this is such a difficult time for anybody at the minute, but especially for you guys that it's very difficult to even get a placement because of the current pandemic. And so we're going to have a little chat about the things that would be best for you to have a look into to prepare yourselves and give yourselves a better chance of actually getting that placement or getting a trainee position job or some way of getting your foot in that door to expose you to it. So if you've got any questions, please just type them in the chat. Our lovely Daniela will regulate the chat there and we can ask me questions then after. And I've got plenty of stories. Oh my gosh, I've got a multitude of stories to tell you. Just to give you a sort of a personal approach to it, to show you how it's affected me and my life and what I've gotten out of it. So I'll start now. Can you just verify that you can see that presentation?
Yeah, we can.
Yeah, you can, bro. Okay. So I don't want to give away the presenter view. So let's say, make sure. Right, so that's just the full screen you can see now, yeah?
Yeah, it's just the screen.
Brilliant. Okay, so welcome to this lecture on the life of a biomedical scientist. So I'm just going to talk a little bit about me and how I got into the profession, really. So way back, and this makes me cringe because some of you weren't even born at this stage whenever I did my degree. Oh, talking about making myself feel old. So I moved over from Northern Ireland to Liverpool to go to John Moores University in Liverpool and did a Bachelor of Science honours degree in Biomedical Science. I loved it. I properly loved it. And I didn't realise at the start, like, no one really knows at this point what you're going to specialise or go into. And it's funny with biomedical sciences because as you progress in this, you become more drawn to a certain area. Listen to your gut, okay, because it's telling you where you should be, okay? So I did my first year and second year full-time students, and then I did a year's placement at the Royal Liverpool Hospital. Now, bearing in mind, this was in haematology and transfusion. I had the time whenever I did biomedical science, we only had 1 hour for haematology and transfusion. We didn't even cover transfusion, actually. It was an hour about B12 and folate deficiency and iron deficiency, and that was it. So they placed me in the Royal Liverpool in haematology and transfusion, and I had the time of my life. I can't even stress that enough. It was awesome. I learned so much and got exposed to so much, like, because Liverpool is such an ethnically diverse place, same as Manchester, really. You got to see all kinds of like weird and wonderful conditions, like specialized conditions, rare conditions, bleeding conditions, and all these different things because the Royal Liverpool was such a specialist centre. So it was always really interesting. So I did my year's placement. Again, I loved it. They were happy with me. So I was very lucky in that they offered me a trainee position. So then I finished my degree part-time over 2 years. So I went to uni 1 day a week and did my dissertation and all of that, passed my degree, and then I did IBMS Certificate of Competence. So it's like, I don't know if you guys have heard of the registration portfolio that you need to do for the IBMS. Now, well, this was, I'm that old, I'm the old way. So mine, whenever I did my Certificate of Competence, it was like a logbook. So you had, in fact, we had lots of sections where they would grill you on all these different questions. You know, if you wanted to get signed off on something, say it was something in transfusion, they would sit there with your logbook, fire you a load of questions randomly from their head, and you had to get it all right. If you didn't, literally, they went, go way back and learn that. So it was quite harsh. And once you got all your logbook signed off, you had to do a tour, take the examiner on a tour of the lab. And then you sat in an office and they grilled you for 2 hours. So you had your 2 lab managers and 2 external examiners just firing questions at you. It was stressful. And you had to look at I had to look at blood films and be able to describe what I saw and all that. Like, even I still remember finishing that that exam and just being like, oh, so tired and like so drained. I couldn't even do any more work after, but it was great. But thankfully for you guys, it's changed now. You will not have that stress. It is much easier to do the portfolio. So anyway, I ended up staying at the Royal for about 12 years. And then I left and become a senior biomedical scientist at Whiston Hospital. And it was there that I started my master's in Haematology and Transfusion here at MMU, and it was the best thing I ever did. I absolutely loved it because I've been so lucky in my job that I've purely, I can't put into words how much I've loved being a BMS. And the job really inspired me to learn more. You know, I would see all these conditions and see all these results, and I'd be like, but why though? But why? And I wanted to know. And when people were coming to ask me questions, I wanted to be able to tell them instead of saying, not sure, I'll find out for you. So anyway, I did the MSc and came out with a distinction. Absolutely adored it. It was hard work, especially working full-time and full-time shifts and everything as well. But in the end, after finishing that, it just, I so loved the knowledge that I gained. And then teaching people as a senior BMS, you're always training people all the time. And that was the bit that I loved the most. So this job came up as a senior lecturer in Haematology and Transfusion here at MMU. I jumped at the chance and I've not looked back since, to be honest. This is how my career has ended up coming about. But so it's going to be interesting to see how your careers are going to take shape, really. So what are the ologies anyway? So it's easy just to call them the ologies. So hematology, coag and transfusion, probably, well, they're obviously going to be my favorite because they're the ones I've specialized in. But biochemistry and microbiology as well have now become, well, heme and chemistry were always 24 hours, 7 days a week, 365 days a year. But microbiology over the last maybe coming to 10 years has really progressed into a 24-hour service, as we're the ones to the right-hand side outside of that circle, virology, histology, all of that. They're more just normal working hours, and they would have an on-call person who would, if something was really urgent, they would be phoned at home to come in. But the ones on the left-hand side is a 24-hour man service. So obviously, I'm going to point out heme, coag and transfusion as the best because they are. But there's one important thing to note here. See, for transfusion, if you don't have a transfusion laboratory on site, you cannot, it is illegal, you cannot have an A&E department. That's how important biomedical science is. Okay, what I want you to take away from this is how much you are involved in patient care. And I mean, oh, I'm giving myself goosebumps talking about it. Like, it was so amazing. The lives that you will be saving is talk about job satisfaction. Honestly, it's incredible. And that little clever little picture to the right is so true, because without us, the doctors are literally just guessing. Okay, most of their knowledge comes from what we provide. Okay, so let's have a little look at pathology. So pathology is huge, just a huge subject. You've got the ones that we've mentioned there before, but you also got molecular biology and cytology, lots of other disciplines as well. So everything's really interlinked, because what you'll find is a lot of conditions are purely systemic. So you can see and detect different conditions just by looking at a certain sets of test results. Like, to me, I think that's incredible. And the more you get into it, the more you see how logical the human body is. Like, for example, if we were talking about somebody that had renal failure, I would be able to tell that from the full blood count results. I'd also be able to tell, have a guidance from biochemistry, looking at the UNEs. So everything's really linked together, and by learning in a case study sort of way, it really helps fill in the gaps. Now, if you notice, I've put a picture of Batman randomly at the side of that. Now, the reason being, that's what we are, my friends. As biomedical scientists, we're the superheroes that no one ever really sees, okay? We're not patient-facing as BMSs. We're in the background doing all the lab work. So for me, that was beneficial. I'm a bit of a softie, so it would break my heart seeing patients. It really would. It's, as you'll hear from some of the stories that I'll tell you, it affects you greatly, some of the things that you go through and some of the experiences that you have within the laboratory. So adding on to that patient facing, I couldn't cope. Plus, ironically, even though I'm a haematology and transfusion specialist for like nearly 20 years, I cannot stand the sight of somebody bleeding. I would literally pass out. Can't cope with it at all. Go figure that one out. But yeah, the fact that we are in the background, no one knows really what we do, which is a shame. But it is becoming more and more open now, really, biomedical sciences, and people are starting to wake up to what we do, especially when you consider things that the global pandemics that we've gone through. And I'm not just talking about COVID-19, I'm talking about Ebola as well. Like, I was heavily involved in that at the Royal Liverpool Hospital, writing the SOPs and our policies for Ebola, for haematology and transfusion, and adapted it right through the other ologies. But I'm happy to be a superhero in the dark, I know who wants to be famous. I am happy to know that because of me, there are countless people that are alive today because of what I've done and how I've been trained and my knowledge and my passion for the subject as well. That kind of thing no one can take away from you. What's in haematology then? I hope you do appreciate my little memes as we go along. I love them. So haematology is really the first line of exploration when it comes to any type of condition, really. It's like the baseline blood test. You know yourself, if you go into, or you watch even Holby City or Casually, we need UNEs, LFTs, FBCs, coag, blah, blah, blah. And that's all you. That's all you. And by the full blood count is so useful. It can tell us a multitude of things about red blood cells, obviously, like everything to do with the red blood cells, the white blood cells, the platelets. So like, for example, red cell disorders, these kinds of things that we're talking about, it's like, I'm sure you've all heard of sickle cell anemia, thalassemia, hereditary spherocytosis, iron deficiency, polycythemia, all of these different red cell disorders, which are so interesting, like honestly, they really are. And I'm going to show you a few things regarding some of these conditions as we move through this presentation. We're also going to look at, you'd also examine white cell disorders. So you're talking about the different types of leukemias, lymphomas. Sepsis is a massive thing. Sepsis kills more people than lung cancer, breast cancer, bowel cancer, HIV, AIDS combined. Yet little is known about it. That's my research area really, is sepsis. But we're getting more and more involved with biomarkers and things like all the different biomarkers like CRP or procalcitonin or interleukin 6, all these different things. We can use these and really examine case results where, you know, say if someone's developed sepsis and someone hasn't developed sepsis, what's the difference in those individual biomarkers? Is there a trend? Can we find anything? And we have so much power when it comes to research in biomedical sciences. And I'm kind of annoyed with myself that I didn't catch on to that years ago. And it's really only been in the last 10 years where I've really started to get into it. But platelet disorders, so things like ITP, idiopathic thrombocytopenic purpura, TTP, Glanzmann's, these different bleeding disorders because of faulty platelets almost. And of course, we've got the parasites as well, the malaria, trypanosomiasis, Loa, all these different types of things that we can look at in haematology. So what does it even look like? What are we looking for? Well, if you look at this table on the left-hand side, these are nice bog standard normal full blood count results. They are beautiful. Nothing to be worried about there. You can see we have the red cell indices. So we're looking at how much HB, that HGB is hemoglobin. Now it's the most important parameter when it comes to full blood counts. And it tells us how much oxygen is being delivered to the tissues throughout. So those with a low HB, we would say they're anemic. We look at different parameters to do with those red cells, looking at the size of them, looking at their appearance, how much hemoglobin is there in the actual sample, looking at the platelet counts and the differential protein profile. You can see diff profile there. That's a breakdown of the individual white blood cells. So like, for example, if you look at the right hand side, there's a graph that is called a differential plot, a white blood cell scatter plot. And that's what we use to visualize the different white blood cells. So they should all be nice separate populations, as you can see in that graph there. We want them separated, all in the right area, so we can just look at it and go, yeah, that's fine. Now, if you were having, say, an infection, a bacterial infection, what you would see is a bigger population of neutrophils, and they'd be left shifted, wouldn't be sitting in the right place, or some of the cell populations might be mixed up because the cells are that abnormal. It's trying to give you a result, but it's going, I haven't got a clue. You're going to have to make a film and look at it. So that's what we would do. And the red blood cell histogram below shows us the average size of your red blood cells. So if, for example, we were going to have a patient that was iron deficient, had iron deficiency anemia, and then they were on treatment, you would get two populations of red blood cell sizes, wouldn't you? Because remember, your red blood cells have 120 days lifespan. So once it's produced, it's going to stay that size. It doesn't go up and down, it's steady. But so if you're iron deficient, you will have a low MCV, the cells will be smaller, but you will also then have this other population of the newly treated cells. So you can monitor the treatment of iron deficiency, etc. Morphology is awesome. Like, this is one of my favorite parts of hematology because it's mad. Like, I could look at a patient's blood film and I'd be able to say whether, you know, you've been on the eel a bit too much. I would be able to tell if you've had been away and you've had some sort of infection and things. There's so many things you can get by looking at the actual cells in your blood. So the left hand side there is showing you target cells. It's pointing out an iron deficiency patient. So you can see the red cells are much, much smaller than they usually would be. As we're below that picture, the bottom picture on the left is the opposite end of the scale. It's a macrocytic anemia. This one in particular is B12 folate deficiency. So you can see this difference in the sizes of the red cells. They do appear different. Then look at the right-hand side, the top right picture with the yellow arrows, those are blast cells. And we would see blast cells in the blood when it's a type of leukemia, if it's an acute leukemia. So chronic leukemias develop and smolder over time, and then, you know, may or may not become worse. Acute leukemias are harsh and fast, and they can come on all of a sudden. Like I have seen before, GP patients coming in saying night sweats, you know, clinical details are night sweats and weight loss. Do the full blood count, the white cell count might be 60, low HB of 70 something, platelet count of 20. And that, remember that differential plot we saw? Instead of it being nice separate populations, they would be clumped together, and not being able to figure out exactly what they are because they're all just blasts and they look like that. So blasts are the most primitive type of cell that you have, and they're fine having them in the bone marrow, and it receives all kinds of signals from the bone marrow microenvironment telling it what it's going to become, whether it's interleukin 6 or tumor necrosis factor. All these different types of cell signaling will influence what that cell is going to be. But in cases of leukemia, remember, leukemia is cancer of the blood. So leukemia cells won't mature. It's like they're stuck in this phase, in this blast phase, and they continually produce more and more and more until literally in the bone marrow it can't hold it anymore and they start to spill out into the blood. And we should never see blast cells in the blood ever. If you ever see it, it's a bad sign. And of course, I've got a story about that. One of the hematology registrars, he was feeling not great, really ill actually, and naughtily, because you're not supposed to do this, took a sample of himself and did a blood film on it and discovered he had an acute myeloid leukemia. Very scary. So imagine looking down into a microscope at your own blood and finding that, which is totally wrong. You should never have done that, by the way. It's totally against the rules. But he ended up diagnosing himself pretty much with an acute leukemia. He had to go into bone marrow transplant, and he died just before his sister got there for the bone marrow transplant from India. So it was really sad, but it just shows you, like, these can come on so quickly. Like literally, that one I told you before about the low HB, low platelets, high white cell count for the acute leuk. 2 weeks previous to that, when I looked at previous results, normal, absolutely normal, just like that first picture I showed you of all the nice normal HB and everything. And in 2 weeks, that's how quickly that came about. So for hematology, it is so important that you can spot these types of things, but don't be scared. We would never let you rip on your own unless you've been appropriately trained and that you feel confident and of doing that job. We would, you know, this is patient lives at the end of the day, and this is what makes it so exciting now, is you have such an impact on this. Like, it's not the power, but it makes you feel incredible. It made me feel incredible, the fact that I was really helping these people, you know. But anyway, if you look at the bottom picture on the right hand side with the blue arrows, they are malaria parasites. Quite difficult to find. Sometimes it is like looking for a needle in a haystack. It depends on the percentage of parasitemia. But this particular parasite infection is Plasmodium falciparum, and falciparum is the most dangerous one. The reason being, it can multiply like you wouldn't believe. Literally gets into a red blood cell, multiplies so much that the cell can't hold it anymore and it bursts. And all those little parasites go out into the blood, get into another red blood cell, and the whole thing begins again. But the thing that makes this really dangerous is the rate of infection, but also it can pass through the blood-brain barrier and cause irreversible brain damage as well. So when we get malaria requests in, we do a rapid test on it. it's like a stick test just to tell us if it's present, and if it is present, is it falciparum? And we'd look at some thick films and thin blood films and then report it back. But the most important thing is to tell them whether it's falciparum or not, so that they could get started on the results and on the treatments. So we talked just there about morphology. As we've progressed through the years, we've now come on leaps and bounds when it comes to automation. And some might argue automation is taking BMSs out of jobs, but I strongly disagree with that, because you will never substitute a biomedical scientist's eyes or their brain. But this digital morphology, so we'll say we get a full blood count in on a patient who has a raised lymphocyte count. This will auto reflex a film. It will automatically make a blood film and stain it for you and pop it out the other side. And you can either look at it through digital morphology, like literally looking at a screen as it's taking little pictures of all the cells, or you can look at it through your own eyes under a microscope. But it helps decrease the turnaround times. And when we talk about turnaround times, which you will hear all the time as a biomedical scientist, it's basically the time taken from the receipt of sample till we get the results out. So obviously we want that to be as quick as possible, but not compromising on the quality either. So hemoglobinopathies, told you this is going to be a bit hematology and transfusion heavy. Hemoglobinopathies, so we're talking about sickle cell here. So the left hand side, you can see now, compare that to some of those other pictures I showed you. You can see at the red arrows the sickled cells, and they are so obvious. Now this patient would have been in sickle cell crisis. So just to quickly tell you briefly, if a patient has sickle cell anemia, if they are in a state of hypoxia, whether they, say, for example, are going for an operation. Now, if you go on to general anesthetic, it is by definition almost a state of hypoxia. And this lack of oxygen will cause this hemoglobin S to crystallize. And what happens is it's almost like they form these stringent, taut crystals, and they become really rigid, the cells. So usually your red blood cells are nice biconcave discs that squeeze into all kinds of little tiny capillaries, etc. Well, these are rigid and stiff, and so they really get caught inside the microcirculation. So things like renal and your kidneys, if they get caught in there, they can cause infarction for that. So you'll end up with renal failure, stroke, pulmonary embolism, heart, myocardial infarctions. And most of all as well, is it's extremely painful. Like you will see them literally bowled over, double in agony from the pain. So yes, it's easy to spot whenever the patient's got in a sickle cell crisis, because you can see just by looking at that, you can see the sickle cells. But for those that perhaps aren't in sickle cell crisis, or they've only got sickle cell trait, then we still need to be picking these up. So back in like 2004 or so, they brought in these guidelines to help patients, give them informed choices, because sometimes some of these certain conditions that you can inherit from patients into a baby are incompatible with life. And so like, for example, hydrops fatalis is a type of alpha thalassemia, and it's got too many gene deletions, and it results in it just not being compatible with life, and the baby will die in utero and will die in the lady. So it's to prepare people for these types of options and give them informed options of what their choices could be. So in this one, you can see in the middle picture, hemoglobin S at 40%. So this would indicate to us that that patient, if they were going to go for, say they were going for a pre-op and going for an operation, they would need transfusion before going into that operation to make sure they've got enough residual HB to carry them through the oxygen loss that they will have during anesthesia. we get all kinds of weird and wonderful hemoglobinopathies though. It's not just sickle cell. Like to the right, there's an example of hemoglobin SC disease, where the patient, hemoglobin C disease is like, it's another sickling disease basically. So hemoglobin SC disease is really quite harsh on the patient, and they will have sickle crisis and things like that. So there's lots that we can pick up in antenatal screening to pass on for informed choice. So moving on to coagulation. So I'm sure some of you have covered it now. Coagulation can be a bit tricky. There's a lot of pathways involved, and even now I still can't remember what this activates this, that activates this. It takes forever to learn that unless you're doing it all the time. So don't worry if you're like, oh God, I can't cope with coag, there's just too much in there. And what we look in coagulation is measuring how long it takes for the blood to clot, essentially. So if a patient was going to theatre, we would absolutely do a clotting screen on them to make sure that there's no problems with clotting, and that when you open them up in theatre, they're not going to bleed to death on you. This is also the discipline that we look after anticoagulant treatment. So I'm sure you've heard of warfarin and heparin. And then we've got the newer DOACs, these direct oral anticoagulants, which have revolutionized the anticoagulant clinics. Warfarin was always very difficult to monitor. So these are for patients, sorry, I should say, anticoagulant treatments for patients who have developed blood clots. So say if they've had a stroke or something like that, they would be put on anticoagulant treatment to try and reduce the numbers of little thrombi that they seem to be able to produce. So you often hear of it being called it thins your blood. I hate that. It doesn't thin your blood. As scientists, it doesn't thin your blood. But it helps to prolong the clotting time so that they don't produce all these little microthrombis and everything. So as were before, warfarin interacts with so many different things, with alcohol, with different foods, with different medications. It's if you overdose as well, because you've got to think as well, these patients that are on these types of therapy are the older generation, the elderly tends to be. So sometimes they might not remember, did I take that pill? Did I not? And before you know it, they've overdosed. And if they fall over, they could bleed to death. So it was very difficult, but warfarin has been in use forever. And now we've moved on to these direct oral anticoagulants like apixaban or rivaroxaban. And the half-life is so much shorter that if they take too much, it's fine because it'll sort itself out a lot quicker than it would do with warfarin, etc. So we do that to monitor all those patients. We've got the really juicy bleeding disorders. So I'm sure you've heard of haemophilia, which is so interesting. And I actually got to meet, when I was doing my MSc here at MMU, we had to do a presentation on a chosen coagulation disorder, bleeding disorder. So I chose congenital haemophilia. And, was writing all this stuff. And because I knew people in the Roald Dahl Centre at the Royal Liverpool, I asked to go in and have a chat with the haemophilia nurses, as a bit of research and whatnot. And she started telling me about this guy who was a haemophiliac patient, and they had him even though he was only like 15 or 16, he was that serious that he went to the adult hospital at the Royal. And one of these consultants, who's the head of the British Standards for Haematology now, Prof. Toe, he looked after him and started this new type of treatment, a new way of treating these patients, and it was so successful. Like, it changed his life completely. But he was able to, I actually met him in the end because she was telling me all about it, and next thing there was a knock on the door and she was like, Emma, you're never going to believe who's just turned up, the £1 Million Man. And they called him that because his treatment was at least £1 million a year for the recombinant factor VIII for the medication that we had to issue in. But even things like he was saying about when he was in high school or at uni, and he's writing essays, he used to have his hand, especially there along where your thumb is, that would be black from bleeding. And you wouldn't think of things like that. It was very difficult for him and for growing up, and limiting on what he could do. But now that man is a teacher, and he's also a musician, and he's written an album and recorded an album, and he's so cool. And it makes me so proud of how all of us as a scientific community have come up with these treatments to really change people's lives. And an interesting point for haemophilia is we've looked into and been successful with gene therapy as well with these patients. So we've actually, in London, it's happened, we have completely cleared someone of haemophilia completely. So they can go out, play rugby if they want, and it's not going to stop them. So this is just a constant changing world in haematology and transfusion, and really interesting. Thrombophilia disorders are ones where you will tend to clot a lot, and you're very thrombotic. So we look at those as well. Hoping you like my little meme on the side, picks a scab, my blood cells. We just spent hours building it. I can just imagine platelets going, I've just done that. And then transfusion. So this bit is the nitty gritty of haematology and transfusion. Okay, this is where you are heavily involved in patient care. Like, for example, you see casualty, Holby City, 24 hours in A&E, even one born every minute. We are integral to those procedures. And in transfusion, we're basically looking at the structure of antibodies and antigens and looking at their reactions to make sure that we can provide blood that is safe and compatible for the patient. Now, one thing in transfusion that I was taught from day zero is never, ever assume anything in transfusion. If you're not sure, you do it again. If you're not sure, you ask for help. You don't just wing it, because here is where you can kill people. So with heme or coag, yeah, we're providing these results and we act upon them. Transfusion, you literally can kill someone if you give them the wrong blood type. So you don't want to go down that road. So we will look at patients' blood types. We will look at whether they have developed any antibodies. We've got massive hemorrhage protocol. So this is a case where you've got a road traffic accident, arrives in A&E, and they want uncross-matched blood, FFP, platelets, get it now, all that type of stuff. This is where it kicks off. It's so awesome, so much fun. I shouldn't say so much fun, but it is. And of course, we've got antenatal care, where we're looking after ladies to make sure that they don't develop hemolytic disease of the newborn, which is a really nasty condition. I won't go into it just now, but those at the bottom are just like typical results that we would see for blood grouping. Now, this is your massive hemorrhage. This is where you are just full of adrenaline. Let's start off with an example. So you are in the lab, it is 3 o'clock in the morning, you get a call from A&E, they need to activate the massive hemorrhage policy. They've got someone in with multiple stab wounds and they're bleeding from everywhere. Just give me it all, give me it all. So they activate this massive hemorrhage policy. And we are so heavily involved, like we're on the phone to a named person in resus, and we've got people coming running up to us to collect blood, and we're phoning them to say when this is ready. We're looking at full blood count results, clotting results. Is the clotting prolonged? If the clotting is prolonged, we're maybe going to need to give them FFP, fresh frozen plasma, to repopulate the clotting proteins to make sure that they can now start to clot. Or we might give them cryoprecipitate, which is like concentrated clotting proteins, like really lots of fibrinogen and factor VIII and fibronectin and these types of things. So on the right hand side, you can see, notice the difference. If you look at HB, it's 57 there. And by looking at the red cell count, I can see, and the hematocrit, the HCT, I can see that there's red cell loss there. Now with this patient, the MCV was, well, a little bit raised, but not too bad. Platelet count was down a bit, so that makes sense. The patient is bleeding from somewhere and is trying desperately to initiate the coagulation cascade, and the platelets get used up on that. Then you've got the white cell count, which looks fine. Coags a little bit prolonged. Fibrinogen is very low, so we would give cryoprecipitate for that. And the calcium's fine, but look at the pH and temperature. So they're acidotic and hypothermic. So these patients are in such immediate danger. You need to act quickly. You need to know what type of emergency blood you can give to to a certain patient. Like what you would give if that was a man come in with multiple stab wounds, say a 25-year-old man, what you would issue to him is different to what you would issue to a 25-year-old woman, because you've got to keep in mind about the patient potentially having a baby, etc. So there's lots of different things that you've got to work into transfusion in these cases. But my gosh, does it ever be rewarding? Oh my days. So maybe at the end, hopefully we'll have time till I can tell you a few stories about these types of things and how it goes on and how it made me feel, and so you will have some sort of idea of how it might make you feel as well. And just these are some of the blood components that we would issue in transfusion. So left-hand side is your red blood cells. So patient has low HB or is bleeding, that type of thing, we would give red blood cells to increase that HB. Platelets we would give to patients that were actively bleeding, and those, say if they've got a platelet count, the normal range for a platelet count is 150 to 400. If a patient had a platelet count of 10 to 20, we would give platelets as well. FFP and cryo, so those two are frozen and we have to defrost them over a period of 30 minutes at 37 degrees. Now this is important, this stage, because it's full of coagulation proteins. So remember, proteins will be denatured if it's too high. And we need to be really careful on how we're defrosting these things, making sure we're doing it at the right temperature, and also being preemptive as well. Like if you say, we'll go back to our patient, our multiple stab wounds in A&E, we've got the coag results now, they're prolonged. So immediately we're putting these in to defrost, even before the guys have asked for them, before the clinicians have asked for them, because I know they're going to need them. And the same with platelets as well. If they're actively bleeding and I need to order platelets, I'll probably order 2 bags from the NHSBT rather than 1. And octoplas at the end is what we would use for plasma exchange patients. So patients that maybe have TTP, which is thrombotic thrombocytopenic purpura, and it's when you get lots of little microplatelet thrombi that goes through systemically through your body and can cause vascular occlusion and cardiac arrest, all kinds of stuff. And the main treatment of that is literally plasma exchange, where you take the patient's dodgy plasma, if you like, out and replace it with new plasma. And for that particular condition, TTP, before we discovered plasma exchange, about 90% of patients used to die because it was so harsh and really fast acting. But after we've discovered this plasma exchange, now we're talking 90% survival rate. So it just shows how important these types of things are. And just a little bit more, sorry, very transfusion heavy. These are some other products that we would give out in transfusion. So prothrombin complex is for patients that, remember we were talking about warfarin and warfarin overdose. So this is like an emergency treatment to reverse that overdose. The RAADP is routine antenatal, I can't get my words out, anti-D prophylaxis, and it's given for RHD negative women that of childbearing if they're pregnant. Now the interesting one is the one at the end here, Novo 7. So Novo 7 is almost like a man-made plug, right? You've got a patient that is bleeding like you wouldn't believe, and you are putting blood, FFP, platelets, cryo, you're giving them everything you can, there's still nothing, still can't help it. If you give them Novo 7, it like sorts everything out. It's amazing, but it is so expensive. You're talking like 1 milligram, that 1 milligram box there is probably about £700, and they go up to a couple of grand. And I particularly remember a patient. He was I don't even know why they put him on this Novo 7, because he was very ill. He was never going to get any better, and he was much older. Like I think he was in his 70s. And it was over a Christmas period. Now, usually, you know, your HB might be 120, say, upwards for a man. It would be a good day if his HB was 45. His bone marrow was just knackered. And for some reason, the clinician thought, the hematology consultant, put him on Novo 7. And he was on Novo 7 for a month and a half. And then he died. And that month and a half for that one product was over £1 million. So when you get to stages like that, is that what we should be doing? Is that ethically correct? You know, all that money on one patient that we knew was never going to survive anyway. So you've got lots of different things coming up in transfusion. And I'll briefly touch on the convalescent plasma. So we were heavily involved in this in transfusion for COVID-19. So we got plasma was taken from survivors of COVID-19, that should contain neutralizing antibodies against the virus to stop the host cells. Now, the COVID-19 antibody levels, it's dependent on loads of things like viral load, how much of the virus is in there, how the body tolerates it. Like, for example, men will naturally have higher levels of or higher titer antibodies than women. And they collect it through plasmapheresis. And basically, we've had these two trials, REMAP-CAP and Recovery. And it was about 15th of January this year, they published the first set of results. And for the REMAP-CAP trial, this was for people who received plasma as part of the treatment, and they had 2 transfusions over a couple of days and were monitored for 21 days to see how effective this was. But they've paused recruitment for this trial now to look at the results, because initial analysis shows that convalescent plasma didn't really improve outcomes. But you know, these things, if we don't try it, we'll never know. As where the recovery trial was closed for it's got about 4 different arms on that, 4 different drugs, like that tocilizumab, aspirin, etc. And the convalescent plasma arm, it was found that there wasn't that much evidence to suggest that patients were really better off with this, because what you've got to take into consideration is things like transfusion transmitted infections and trally, these different conditions that are risks of transfusion. So that article at the bottom is the results to the trial if you were interested in having a look. Right, you'll be glad to know that's the end of the hematology bit. So we'll just chat a little bit about biochemistry. So biochemistry is analyzes the bloods and other biological fluids, and it's for the diagnosis of diseases like diabetes, Graves' disease, whatnot. And these clinical chemists carry out toxicology studies as well, toxicological studies, kidney and liver function tests to monitor therapies. What you'll find with biochemistry is hematology and transfusion is very much different from all the other ologies. Heme and transfusion is very hands-on, where you're making your own decisions and your own choices, and it really does rely on your knowledge. Not to say that biochemistry, you don't have to know what you're doing, of course you do, but it's a lot more highly automated, just simply because of the amount of samples that they have to process. Like you're talking maybe, I don't know, 3,000 samples a day. And of those 3,000 samples, there might be 10,000 different requests, test requested. It's that extensive, really. So they will test serum, plasma, urine, different fluids, CSF, etc. So they'll look at enzymes and electrolytes and toxic drugs, cardiac markers, tumor markers, all your vitamins and minerals like vitamin D, vitamin E, B12, folate, all these types of things. So like LFTs will tell us whether your patient's got anything wrong with the liver, quite obviously, because it's liver function tests. If you've got high LDH, then there's some sort of cell death going on. It could be hemolysis as well. Bilirubin, you've all heard of that. Troponin down at the bottom. Troponin is a cardiac enzyme. So high troponins would be suggestive of like a heart attack. Lactates are high. We would see high lactates in sepsis, say. Obviously, we'll do HbA1cs. So there's loads that you do in biochemistry. But generally, with biochem, now this might be skewed because I'm a hematologist, but if they get, say they get like a really high potassium result, they might look at that result and go, rerun it. And they'll rerun it, get the same result. Is the QC okay? Yes. Is this okay? Yes. Well, must be right then. And off they go. And it gets sent out, then that high result goes to a clinical biochemist. As we're in hematology, if I get that high result, I do something about it. I decide what tests I'm going to do next. I decide what I'm going to phone the clinician and say, or whether I'm going to send off for some other tests. So for me, hematology is a lot better. So what about microbiology and virology? So micro test urine, feces, mucosal and soft tissues, fluids, CSF, blood culture, swabs, all of these types of things to try and detect a type of any infection going on. So obviously you get, I'm sure you've heard of blood cultures. So if you were querying an infection, they would take blood cultures, aerobic and anaerobic, and they're taken in these little blood bottles, well, little, they're quite big actually, these blood bottles, and they're placed into like a incubator, and they are cooked, kept at 37 degrees for up to 72 hours to see if anything will grow. How do we know if it's grown? Well, the colour at the bottom of the glass bottles will change colour, and that will alert us that there's something growing in there. And what the BMS then will do is take them off and plate them out on agar. And if they're still not really sure what it is, then they've got this bonanza of a test. Have a look at that on the picture on the very left-hand side. It looks like a giant vending machine. This is the coolest thing I've ever seen in micro. So it's actually a multi-top mass spectrometry analyzer. So you see on the, I wonder if I can post. See that little slide with all the little dots on it? So say you've grown something on the plates and you're not entirely sure what it is. You put a little bit of that mold or whatever that's grown, pop it on that microarray plate, stick it in the analyzer, and literally it's what it does is, I'm going to try and describe this because it might give you a better idea. So imagine it will target this slide, and it goes into a high vacuum environment, and then this laser, it's really precise, it bursts and ionizes the sample. So it's, imagine it just a laser going on to that little point, and it goes poof, and the flight of those proteins, a cloud of proteins will be released, and how long and how far that flies and where they land will tell us what that actual infection is. And I think that's so cool. But yeah, it's really fast and really accurate, and yeah, it's what happens is where the actual particles fall is checked against like this database, and it's matched up, and then it'll just literally print out or send off the results to say to you, yes, this microbe is this, or this virus is this. And you get the results within an hour. I just think it's amazing how they've done that. So next, this is where microbiology has completely come to the forefront. Like, I couldn't be prouder of this discipline as what I am this year. So I went into micro lab. So these pictures were only taken a matter of weeks ago. And I couldn't believe the difference in that laboratory and how the analyzers, the amount of new analyzers in there as well. So many machines have been repurposed to test for COVID-19. And it's amazing what they've done. Like, you should see the thousands of samples they've got to process. And you can imagine how such an emergency that this has become, and microbiology have just reacted in the best way and have really pulled through for biomedical scientists, really. Some of these analyzers will only take less than an hour to get this result off. And say for the top left-hand corner, the Gene Expert, literally, this is how easy some of these tests are. 50 microliters of blood in it, stick the cartridge into that PCR analyzer, press play, and within an hour it'll tell you whether the patient has COVID or not. I mean, a lot of these analyzers were not supposed to be used for COVID. They were specifically for other tests, but what they've done is repurposed them and changed them up. Like, for example, that's see if I can get this one with, it says E on it. That's where you stick the swab into that little blue compartment. Gosh, I'm trying to get this. And you would put the swab in here, pop it in that machine, and off it would go to tell you exactly what was present. It's really incredible what they've achieved throughout this pandemic, and it makes me incredibly proud to be a biomedical scientist. So histology. So any of you have got strong guts, this might be for you. Not for me, I'm afraid. So on the left-hand side, the first picture you can see is cut up. So say, for example, you have the GP is querying bowel cancer or something like that. In theatre, they will take remove some of that bowel. Be sent as histology. They will do a cut up, so they're cutting it into much smaller pieces. It then gets embedded and waxed. It gets sliced so super thin, like I'm talking like micrometers in a cell length thick, so that you can look at it under the microscope. Now, in the middle picture where it says embedding, if you can see that tiny little piece of tissue, that's from the prostate gland. And so they've been embedded in molten wax there, and on the right hand side is an example of how you would cut that then. And then you can label it with different antibodies, etc., to try and show this staining up, to try and find the presence of any abnormal cells there. Histology smells amazing, by the way. It's weird as well, like all those chemically smells, but it's dead nice. You know, if anybody likes TCP, that kind of a smell, it's quite nice. Now, histology is where we look at big samples, you know, the big pieces of tissues, and we cut them down and look at them microscopically. Cytology, you're talking a cellular level here. So it might be lung fluids, or the main groups of is gynecological and non-gyne. So your gyne would be cervical screening. Non-gyne, things like if you're having a fine needle aspirate, say if you're querying breast cancer or some type of condition like that, so you would take a sample, a biopsy, and on the right hand side, the top picture is like it's a part of an analyzer called a cytospin, and you put the glass slide, see where that brown bark is, put your fluid in the funnel, and it gets spun, and as it's spun, the cells settle on the glass and are fixed there, and then we can stain them. So cytology is another growing place, because I mean, you know how how many like cervical screening, how unpopular it is. Not so much popular, but we know now how important it is for cervical screening, don't we? And, you know, they're trying to get this done, people being screened earlier to save lives. It's really amazing what they do, to be honest. Then we've got immunocytochemistry. So these are massive analyzers, and we use labeled antibodies to be able to identify what's present in the tissue. So it's immunology. It deals with the conditions of the body's immune system, quite obviously, and its role is infectious diseases, parasitic infections, etc. But immunocytochemistry is where we have a formalin fixed paraffin embedded tissue section, and we stain it with primary antibody that's directed against a specific protein target, and a solution then containing this primary antibody is added to the tissue section, and the antibodies are allowed some time to be able to, you know, find their target and bind to it, and then we wash away any surplus antibody, and we carry some of these carry like linker molecules like horseradish peroxidase, different types of things like that, and it helps to stain up these different the target things that you want to find, basically. So you see that that's brown, that brownish precipitate there. This is a piece of tonsil tissue actually, and it was used in anti-CD20 to be able to highlight these cells to show us if there's anything abnormal there. This is actually fine. That's not showing any abnormality. So also we have molecular biology. So this molecular biology and cytogenetics have just become more and more vital to biomedical sciences. The biggest thing about these types of things is it allows us to stratify a patient's therapy. So I'll give you an example. Let's talk about polycythemia rubra vera. So polycythemia is where you have too many red blood cells. So you're thinking, oh, well, that's not going to be too bad. You're going to have plenty of oxygen there, you know, be able to run faster. Not the case, I'm afraid. So polycythemia is when you are producing way too many red blood cells. And the consequences of that is your blood can become really viscous, and you can end up with stroke, myocardial infarction. Just imagine how sludgy your circulation would be with way too many red blood cells there. So usually, say if you are anemic and your body, your renal system will detect this and release erythropoietin, the hormone that's responsible for producing red blood cells. So when the erythropoietin binds to the cell, it binds to this tyrosine kinase protein on the cell surface, and when that binds, it phosphorylates, and that phosphorylation signal travels right the way down till the nucleus and tells it to upregulate the production of red blood cells. Once we get to the normal level, that erythropoietin then lets go, and the red cell production stops, and that's in a nice normal way. In polycythemia, that protein is defunct. It's constantly turned on. So as soon as that erythropoietin binds to that, even if it lets go again, it still asks for more and more and more red blood cells to be produced. Now, because of molecular biology, we can look at that and find that that patient is has a JAK2 mutation, in which case we can look at a certain set of immunotherapy that will help with JAK2, and they've proved to be completely remarkable. Drugs like ruxolitinib or the newer momelotinib have proved incredible for these patients. So the mortality for these types of conditions has dropped a lot. And so molecular biology is looking at the problems, the etiology of a condition, but at a molecular level, looking at the actual proteins themselves rather than the genetics of it, looking at the proteins and seeing what way we can manipulate that so that we can give them stratified treatment, like give them treatment that we know is going to work for them. So these are usually based at, there's some at the Royal Liverpool the Liverpool Women's Hospital, Manchester as well. And then we've got molecular genetics or cytogenetics. So you might recognize this. This is FISH. So fluorescence in situ hybridization. And what it does is it allows us to identify any genetic abnormalities, like certain ones, like for CML is chronic myeloid leukemia. And one of the most common causes of it is this Philadelphia chromosome. And with this, the Philadelphia chromosome, you have a detection. We use it to detect the translocation of chromosome 9 and chromosome 22, where they bind together and create this BCR-ABL protein, which we call the Philadelphia chromosome. And we see this in about 90% of CML patients, and it confers like a cancer, basically. It's uncontrolled proliferation of these cells, and we can detect this through molecular genetics and then use the appropriate treatment for that particular patient. And these, again, this has revolutionized hemato-oncology massively, molecular genetics, to the point now where if we're talking about hemato-oncology, which is a huge area, so all your leukemias, lymphomas, that type of thing, we've got a thing called HODS, which is Hemato-Oncology Diagnostic Service. And with that, we would, if a patient is querying leukemia, you would take bone marrow biopsies, full blood count, send it for immunophenotype, and you do molecular genetics, cytogenetics, biochemistry, all these different, and histology, loads of different tests. Now, it used to be a case of they'd go to all the different labs and then the labs would report the findings, but they all don't necessarily marry up. And like your histology might look like, oh yeah, that's definitely a lymphoma, Hodgkin's lymphoma. But yet, no, you're looking at the cell marker results, the immunophenotype, and as in what's expressed on those white cells looks nothing like lymphoma. So it was really difficult. You would have these conflicting decisions from different doctors about it. So HODS what became a central service to feed all of those different tests in. And then you've got this multidisciplinary team that will look and analyze all of those results and stratify these patients and say, yes, this is exactly what's wrong with this. Even though that shows that and that shows that, looking at it all together, this patient definitely has this. And in which case, we can use this therapy for them. This will definitely work. And that's how HODS works. It's amazing the difference, the lives saved from even just that coming together has been incredible. So how do we get in then? How do we get a job? Like that little picture. Often I'm sure you're saying, oh, you need experience for this. Well, how can you get experience when you can't even get in to get experience? It's very frustrating. I completely understand that. So if you wanted to be a biomedical scientist, then these are the things that you need to be thinking about, okay? So a registration portfolio, everyone has to do it. And it's like a basic portfolio where we talk about what we expect from a biomedical scientist, talking about quality, equality and diversity, all different things like that. That can be used to get into biomedical sciences no matter what discipline you want to choose. Now, if you want to go into histology or a heme, doesn't matter, everyone does the same registration portfolio. And then after that, after you've completed your registration portfolio and your HCPC registered, etc., then you can go on and do your specialist portfolio where you've chosen your discipline that you want to carry on working in, and then you learn even more about that. It's much more discipline specific, so you'll talk about the different tests that you do rather than just generic stuff. Personal statements are super important. We want to see, because I used to hire trainees and students and stuff to come in to the lab, so I know exactly what we're looking for. So personal statements. I want you to tell me why you're good at this. Why do you think you'll be good at this job? What excites you about being a BMS? Why do you want to go into this job? You know, start off with like a page and just you fire everything down on that. You write down what your favorite, what interests you the most, what really gets you about human biology. Where do you see yourself wanting to work? You know, maybe you know, you still don't know yet, but you know you want to give it a try. That's perfectly fine. We don't expect you at this point to know what you are going to do forever and ever. Amen. You know, that will all come to you as you progress in your degree and etc. Expressions of interest. So say you want to come in to have a look around a lab, or there's a trainee position coming, you could write a letter that expresses your interest in it. I have covered these topics in my undergraduate degree. I did particularly well in this aspect of biomedical sciences. What do you think you could get out of it? What can you bring to the table? You know, what's your own personal goals? And you're trying to sell yourself here. You need to tell me and sell me you. Show me that I'm definitely going to want to take you up. Have an up-to-date CV. Always have an up-to-date CV. And LinkedIn profile. I honestly see only since I really started in this job as a lecturer, did I really start properly looking at LinkedIn, and I wish I'd have done it years ago, because my LinkedIn profile has just exploded now. And it's really good. Like, I had a random message from a member of the World Health Organization asking me to help out with this point of care device. Only it was biochemistry, and I'm not interested in biochem. I would have took him up on the offer. But I mean, how random is that? Someone from the World Health Organization contacted little old me on LinkedIn. So get yourself out there, get your profile done, show them on that what you're interested in, but we'll talk about that in another wee minute. So your portfolio, get on to the IBMS website, and I can bring that up on screen after this presentation and show you like around about it. But this is what I was talking about. This is what you will have to do to be a biomedical scientist. So you can see the contents, it's actually quite short. There's 10 different modules in there. And basically what we want is examples or pieces of evidence that show me you are capable of doing set out tasks, right? So let's have a little look and see what we're talking about here. So number one, if we look at the knowledge section on the left-hand side, if I can get my key thing over there. So here, the knowledge section. So knows the limits of their practice and when to seek advice or refer to another professional. That is one of the standards of practice. That's what SOP stands for, standards of practice. We would expect you, if you were, it's almost like if you were feeling out of your depth and you didn't really know what to do, what would you do? Well, we'd want you to put somebody else on, like say someone's phoned and said, hi, Dr. blah, blah, blah here. I've got this patient results for patient X, and this result is really, really high. What does that mean? Well, if you don't know, don't try and blag it. Pass it on, just say, I'm not entirely sure, but I'm going to get someone on the phone that can explain it to you exactly what it means. So knowing where you are, what the limits of your practice, have you been signed off to do that? And literally just showing me, giving me an example of when that's happened will meet that piece of evidence. So this is like, this is quite a packed unit, actually, this module. And there you can see like there's 15 and then so the left hand side is knowledge, what we expect you to know, you know, by the end of this. And competence is what I'm saying, you do know how to do this. You are capable of doing this. So the left hand side is knowledge, where I will sign to say, yes, they understand all of this. They have demonstrated it to me. On the right hand side is, I've seen them do this. I know they can do this. So things like let's see, did I put some in here? There you go, in the middle there. Evidence 2, situation beyond my scope of practice. So this is actually a real portfolio, one of the last portfolios I not moderated, but I was his mentor for. And Daryl did extremely well. He was told by his examiner that it was the best portfolio he'd ever seen. Now look how messy that is. Now that is a beautiful portfolio. I don't want to see super duper neat and tidy stuff. I want to see evidence of you looking at something and going, actually, I'll write about that and put this on it, highlight the life out of it, put pictures in there, show me, tell me how you are meeting these different standards of practice. So if you look at evidence 2, he's saying that he got a phone call from the antenatal clinic about anti-D quantifications. Don't worry if you don't know the subject that I'm talking about, but so they were starting to ask him questions, but he didn't really know. He had only just got into transfusion, so wasn't really aware of quantifications, etc. So he got the senior in transfusion to come on phone and explain to them, and then he spoke to that senior afterwards and got it all explained to him so that he could understand that. He wrote that up, showed me like that patient notepad to prove that he did do it, and annotated it all, told me all about it, and tick, that like ended up being like ticking off a load of these, because you only are supplying 3 pieces of evidence for each one of those units. So each piece of evidence must tick a lot of those boxes. Yeah. So for example, that particular one we were talking about there, about the anti-D quantification, that would satisfy number 1, 2, 3, 4, and so on and so on. And the mentor, like me, would go through it, mark it, make sure he's annotated it enough, put everything in there, covered everything that needs to be covered, and got the most out of that piece of evidence. And then on the very right hand side here, you give the titles of your evidence and you're saying why I've included that. And that's exactly how you fill out your registration portfolio. It's always more difficult to get it started because, you know, it's new to you. But once you get into the swing of doing it, it's dead easy, really easy. Now you're probably thinking, yeah, but I'm not even in a lab yet, mate. How am I going to get to do this? Well, there's some that you can do at home before you've even got in there. So let me see if I can find it. Like, for example, equality and diversity. And that's like proving that you can work with people that are a different ethnicity to you. You know, you will not treat anybody different. Like, for example, Jehovah's Witnesses. So Jehovah's Witnesses do not accept transfusions. Some accept some types of things, some are pure devout and won't accept anything. And I have come across this a couple of times in my career, and I have come across it where the patient died because they wouldn't accept anything. A simple transfusion would have saved their lives, but you know, that's their beliefs, and that they're completely entitled to that. And I would never in a million years ever, you know, treat anyone different or treat their samples different or anything because of what they believed in or what religion they are. And that's what you're trying to prove in these different things. So although you haven't been in the lab, what have you done in your own jobs? Like, for example, if you worked in Tesco's, all right, say you worked in Tesco's at the information desk when people were bringing stuff back that were faulty or something like that, you would never treat your customers different because everyone is equal. And you could put that in there and say how, you know, on this one time I had this situation where this occurred and I dealt with it this way, and showing that you can practice like and conduct yourself in that way. It's, yes, it might not be completely satisfying this portfolio, but having that done before you even get into a lab, showing them that you know what you're doing. You're aware of the IBMS portfolio. You know how to fill it in. You've been proactive and started doing it. Oh my goodness, that will set you up so well. Okay, because I'm sat there as an interviewer. You've got to convince me that you really want this job and you're dead serious. You know how competitive it is. So prove to me I should be giving it to you. And if you've started this portfolio and start collecting evidence, and you can show me that evidence and you can talk me through it, even though it's not properly based in the lab, I will be impressed, because I'm like, well, they clearly have researched this. They know what they need to get the job. They're proactive about it. Ding, 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 ding. All stands you in good stead, honestly. So I highly recommend get onto the IBMS website, download the free copy of this IBMS portfolio, and just have a read of it. Familiarize yourself with it and have a go at it. If you need to, or if there's some way that I could do it, I can put up links to these portfolios or whatever at the end and show you how to get about. Okay, so portfolio verification. So you fill out this, you complete your portfolio. So you should have 30 odd pieces of evidence. And you will do a lab tour. So you'll take them round your lab. You say, this is haematology. Here we look at this. And this is the analyze. This is full blood count analyze, and it works by doing this. And samples get read here, and the results come out here. And this result means this. And you just sort of talk your way through the lab as a tour. Then the examiner will take your portfolio off, go away off with tea and biscuits, and sit there all afternoon and not read everything, but they will scan through it all. And then you will find out later that day as to whether you have passed or not. It sounds a bit scary, but honestly, it's not. And you would get to do loads of practice tours around as well to do that. So once you've done the registration portfolio, you can go on. Remember I said about the specialist portfolio. So doing your discipline specific stuff. So if you were going to do biochemistry, you would learn all about your UNEs, LFTs, why you're doing them, what are they raised in, what does that mean, all that type of stuff. You can do specialist diplomas, higher specialist diplomas. Now, as the higher you go with this IBMS, the tougher it is. I won't lie to you, it's tough, but it's also really good. And also, coincidentally, guys, I know I've put that up on the left-hand side. That's actually expired now. I forgot to take that off. If you are a final year student, undergrads, you get your IBMS membership for free through the university. So just a tip about that. So again, have a look at what experiences you have done. Have you worked in a GP setting, a care home, etc.? Anything that is healthcare wise, that's where you need to be dragging, getting your key skills and everything out from. Like, say we talk about a GP surgery. Okay, instantly you have experience about confidentiality, patient confidentiality. You treat all your patients the same, equality and diversity. You need to have good communication, both to the patients on the phone, the patients in the GP surgery, the doctors themselves, lab technicians like BMSs. You need to be able to communicate between all of those, and that's great for a biomedical scientist, because you need these types of skills are all transferable. So although that was in a GP surgery, you can still take that skill into the lab. You can still know what it means to practice with confidentiality. You still know what it's like to communicate in different levels. So try and think of the skills that you have obtained from different jobs, even if it is working in a shop. You've still faced customers. Maybe you've diffused angry situations or things like that. Just have a little think about the different skills that you have picked up from different jobs that will transfer to somewhere else. So a good way of trying to get in is the medical laboratory assistant. So in the laboratory, you will have an MLA, and then a BMS, a biomedical scientist, then you will have a senior BMS, manager, etc. And then the pay scale goes up off. So an MLA will, oh my gosh, you'll have ample opportunity to fill in, complete your portfolio through that. Ample opportunity. And you'll get paid, obviously. The kind of things that you will do as an MLA will be setting up analyzers, making up buffers, sometimes carrying out certain tests like glandular fever. And you're heavily involved in the lab. Like, we could not work without MLAs at all. So it's a really good way of getting your foot in the door for BMS. So trainee BMS positions, once you've finished your degree, that is perhaps where you need to be looking. Now, these are almost like hen's teeth sometimes. It's a lot more difficult these days because biomedical sciences is a lot more widely known compared to what it used to be. So sometimes the best way to do it is to do it through an MLA. So I know that I've tutored 2 in the last year that were MLAs, and we carried on with them getting their portfolio and stuff done so that when a trainee position came up, they could apply and they still had all of that portfolio work done. And that girl has now passed with flying colours, and she's a fully qualified BMS, and she started as an MLA not that long ago. Keep your CVs up to date. Personal statements, remember we said before about, you know, you want to list your best qualities. What are your strengths? You know, are you good at organizing your time? Unlike me. Reflective practice, oh my goodness, that's what they do all the time in BMSs, right? If you make a mistake in the lab, you will have to write a reflective practice. What did you learn from doing this? But it's a good way of getting into the swing of it, because you will do a lot of those types of things, and that's how we evidence stuff as well as a BMS, is reflective practice. So as when you are a BMS, you will have to do CPD, continual professional development, and you'll build up your own portfolio of examples of you constantly learning. And a way of doing that is reflective practice. So say for example, you started in transfusion, and you typed a request in, the patient wanted blood, and it was a really weird group or a bizarre reaction, and it's not exactly what you expected. Then you work through it, you know, maybe with another BMS, and then you write up afterwards and say what you've learned. Well, this time I've never seen this before, this came up, and now I feel confident that I will know what to do with it next time. And that's basically what reflective practice is, and you will do that all the time as a BMS, so get used to doing it. And the other thing is word of mouth. I can't tell you how important that is, okay? Because if you know anybody that works in a lab, use that. Go ask them if they've got any jobs going, or ask them if you can come in for a look around. Always ask if you can come in for a look around, for a tour of the lab, because I mean, I know it's going to be difficult at the minute because of COVID-19, but to me, if you asked to come in and you looked around the place and then you came back for an interview, I'll be like, oh, I remember them coming in. Shows me that you are actually really serious about this, because you came in to have a look for yourself and then you've applied. Yeah. So if you know anybody in the labs, get on to them. So why bother being a BMS? Because it's amazing. I can't tell you the job satisfaction that you can get. Well, I got from it, knowing that there were so many people, you know, that wouldn't be alive today if it wasn't for my fast action. And I know that sounds a little bit conceited, but it's true. All the same, it is true. And the research opportunities that you guys will have, you know, and how involved you are in this whole pathway and in the NHS, like working as a team, it's the most amazing feeling. And I thoroughly adored my time as a BMS. I loved it. and I would highly recommend it to anybody. So just quickly again, LinkedIn profile, get it sorted. There's some example of a bit of mine. So I put a little bit about myself, put my job history and my education history. Don't be afraid to request people as well. This opens so many doors. Remember what I said about that guy from the World Health Organization? I mean, like, flipping heck, how did that happen? But you know, these are the types of opportunities that can come up for you. Plus, so many jobs are advertised on this as well. So get onto LinkedIn. That's the end of this presentation. Do you like my little neutrophil to the left? And the right-hand side, this is because it was Valentine's Day yesterday. The right-hand side, my friend spotted this on a tissue section on Friday. So that's it. I will stop sharing my screen and you can tell me if you've got any questions. Hello, have we got any questions?
I have a question.
Okay.
What's the most memorable moment from your time working?
Oh, definitely it would be that night that I had 4 emergencies in the one go. Oh my days. So it was about 1 o'clock in the morning. It was one of my first shifts doing on call. So when we say on call, by the way, we are in the lab. It is not on call from home. Doctors get it easy. And it hit about 1 o'clock, 12 o'clock, 1 o'clock in the morning, and I get this phone call from A&A. The massive hemorrhage pack activated. We've got multiple stab wounds, blah, 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 blah. I'm like, oh, yay, something to do. So you're putting in blood, FFP platelets, all that kind of stuff. And then I get a phone call from theatre on the 11th floor saying we've got a ruptured aneurysm, a ruptured aortic aneurysm as well. So the aorta, that the blood vessel that feeds into your heart, you can imagine the amount of pressure that is in there. So when they bleed, I mean, it is one of those where you see it going like that out the body. And when they bleed, it is unreal. So I had that on the go, who was a different blood group from that other patient from my stab wounds. Then I had, fast forward like an hour. So all of these are still going on. Then I had a lady at Liverpool Women's Hospital that had multiple births. So I think she had triplets, but she had antibodies as well, and she was bleeding. And obstetric hemorrhages are, oh my gosh, because when a lady is pregnant, they're very thrombotic. You have lots more plasma proteins like fibrinogen and clotting factors and stuff. So they can clot really easy, but they can bleed a lot, especially if it's a placental abruption. But anyway, because this lady had multiple antibodies, I couldn't just go, right, APOS, you have that. I had to take the APOSs and manually test the patient's plasma against these donor red cells to make sure that they wouldn't have any reaction. So it took a whole lot longer. So it got till about 5 o'clock in the morning. That lady was still going off. Then I get a gunshot wounds in A&E. I'm like, are you messing? Are you messing? Would you look at how much it's going on? But you know what? It was amazing. It was, I'm giving myself goosebumps here. It was so brilliant. Like, one, I was very much aware of being careful that I could cope with it all. You know, it wasn't just all 4 at the one time. They were still going on, you know, but it was just incredible. All the babies survived. The woman survived, the women's. I think the gunshot wound died. The hemorrhage, the aortic aneurysm in theatre survived, and my stab wound survived. And like the thought of, if I hadn't acted like that, you know, dead quick and knew what I was doing and really paid attention to what I was doing, I could have killed somebody there, especially when they're different patients with different blood groups, with different blood samples, with different results and all this, and you're trying to process them all. And it sounds a bit like scary, but honestly, like the day shift staff come in and I was like sat like that with my head on the table and they were like, oh, are you okay? I'm like, that was the best shift ever, because it was just so adrenaline fueled and it was really meaningful. You know, this is what I'm here to do. this is what I'm here to do. And it was just amazing. And like, that was one of my first on-call sessions. And it's still now, I still get all goosebumps thinking about it. It was brilliant, absolutely brilliant. So yeah, definitely that one.
I love how enthusiastic you are. It just makes everything come to life more than just a lecture. And
oh, it's so great. Like, seriously, guys, I can't tell you enough how involved you are going to be, whether it's heme or transfusion or biochemistry or micro. You make such a difference to patient lives. If it wasn't for you, they will die. We can't be without you. So, and it's a bit sad that biomedical sciences doesn't have it's not as overtly seen as like a doctor or whatever, but I tell you, you're every bit as important. And as well, I have friends for life now. The people that I've worked with over the years, some of them like have no doubt will be godmothers to my children type of thing. And it's such an amazing atmosphere to work in. And anybody that works in healthcare generally has the best heart as well. They do it for the love of it. And like, it's just incredible. I thoroughly enjoyed my time as a BMS. And you probably think, well, why do you leave? Well, because I did everything I could do, I think. And I was ready for a different challenge, and that's why I've left. But like, it's still very much in my heart. And like, when it comes to COVID and everything that's gone on this year, I was still, last year, I didn't leave the NHS till July last year. So it was a very scary time when COVID came in. Like, we were getting samples down and people were like, I don't want to touch it, I don't want to. And then because I'm a senior, I was like, well, give it here. And so I was processing them, but we were terrified because we didn't know how it was transmitted. Could you get it through blood? All these different things. And even though, we're working with people, I don't know if you're infected or not, you might be asymptomatic. And it was dead scary. But the way that the health service has pulled together and what they've done is just amazing. Like, look at the vaccines, this is the virologists, the microbiologists, the immunologists that have come up with all of this. Like years ago, how long it took to get a vaccine done, as we're, yes, now we're in a much better position. Like, this isn't 1965 anymore. We've got brilliant analyzers and new techniques and things. And the fact that everything else has been put on hold to try and figure this out, I just think it's insanely amazing how the NHS as a whole have just performed in this. Like, I was involved in the whole Ebola thing. Now that was scary. Oh my days. Because we knew what Ebola was, and you had to because the time when Ebola came out, do you remember this, don't you? Whenever it was only a few years back, and the Royal Liverpool was named as one of the designated sites for repatriation for patients from Africa. And so we had to develop a way of testing these samples, but without cross-contamination and everything. So like, we had to come up with this buddy system where you were doing one thing, but the other person was watching everything you did to make sure you didn't touch anything you shouldn't touch and all that kind of stuff. But like, I'd used to carry the bleep with me, and the bleep would go off, and I have to phone, and they'd be like, there's one coming in, but you had to be quiet about it because you didn't want people to freak out and stuff. And it felt great to be a big part of that as well. So there's always lots of new and exciting things that comes along with being a BMS. You guys are going to love it, honestly.
Michael's asked, did you mention that you worked at Wiston Hospital?
Yes.
And if so, did you enjoy your time there?
Yes, I worked at Wiston over the last 5 years. I started there in 2015 and then left to come to academia. Yeah, it was brilliant. Wiston was lovely, a really nice place to work. The hospital's gorgeous, and they've won. Haven't they won like best CC? That's CCQ. I can't remember. The awards where the best patient care and stuff. They've won the awards for that, and they are that good. They're amazing. Wiston was brilliant, and you get to see loads. Like just to prove how I've even got my nephew into biomedical sciences now. So he's now currently doing his year's placement at the Royal Liverpool, where I studied. And he's loving it. Like, so I wouldn't get my own family on board if I didn't think it was worthwhile. But yeah, Whiston was awesome. Do you know anyone at Whiston, Michael? Probably not. Any other questions?
Millie was wanting to know if there's any lab accidents that have happened.
Okay, this is being recorded, isn't it? I have to be careful what I say. So one stupid thing I did once, so I was just a trainee, I hadn't long started, and I was working with this MLA called Bobby, and he said to me, what happens if you put dry ice in a bottle, put the lid on? I was like, do it and see. Oh, I shouldn't have said that. So we put the dry ice in the empty Coke bottle, put the lid on. I'm like, unscrew it now. I was like, why? You just see the bottle just going bigger and bigger and bigger. And I was like, oh my God, throw it out. Because it was going to like explode. And he managed to just get the door open, threw it outside, and it went. And unfortunately, there was a couple of people from the lab out having a brew on their breaks. Tea went everywhere, cake went everywhere, and I was like, oh my goodness. But like generally not too bad of accidents or anything like that. That was really silly of us. We never did that again. And we nearly got caught out by the haematology consultant. So, but other than that, no, nothing major.
Michael said that he did work experience there and met the manager called Chris. At Whiston.
Oh, Chris McKeegan. Was it? Did he have blonde hair? He's not there anymore if that was him. But yeah, definitely MLA positions, guys. Get your foot in the door with that. Anything else?
I have a question from one of our committee members that she got kicked out of the library, so she had to go off the chat. She says, with things moving more towards automation, how might that change for job prospects, do you think?
I don't think it's not changing it that much. This has been a fear that has been instilled in us since I became a BMS. Oh, everything's getting more automated. There'll be no more BMSs, and that has not happened at all. You can have analyzers till they're coming out your ears, but if you've not got the brains to run that, there's no point having them. So what you'll find is the automation is there for the sheer volume of samples that you get, rather than taking the BMSs out of the equation. You are always going to need BMSs. Like, it's like what I said about that digital morphology. Yeah, it's great, but it also has limitations. Like, it can be caught, it's going to try and tell me what a blast is, but it's not going to be compared to my eye, you know, in my experience. So yes, automation is getting more and more, but I've still not seen a big effect on the staffing, to be honest. So don't worry. And don't forget as well, guys, it doesn't necessarily mean that there's just the NHS to work in. If, like, transfusion wise, you can go into the NHS BT, now, you know, the blood and transfusion services. You can go into organ transplantation and etc. in there as well. You can go into forensic science. You can get into mortuary stuff. I don't like that. It always used to freak me out having to walk past the mortuary in the middle of the night. I'm like, don't like it at all. But yeah, it's dead good.
And Charlotte said also that the analyzers have issues and things like that too.
Yeah, analyzers definitely have issues. So, like, one of the things, if you were going to be an MLA or a trainee BMS, is working the analyzers. Now, when you first go into seeing them, it's like, oh God, what is that thing? But it's actually you'll be trained on how to use it, how to set it up, and they'll explain these things to you. And like, say, for example, if you've set up the analyzer in the morning and you're going to run the controls, you get control failure. Well, then we would expect you to be able to investigate that and figure out what's gone wrong and rectify it. So it might be a case of somebody's made up the control wrong, or it hit an air bubble, or, you know, things like that. And there are investigative procedures to find out what's gone on. But yeah, good. Oh, Charlotte Felton, I've just seen her there. Hello, sweetie. But yeah, and keep an eye out definitely on LinkedIn, because I was talking to the lab manager at the Royal Liverpool Hospital the other day, and she's going to start putting more and more stuff job-wise on LinkedIn. So it is really good for opportunities, job opportunities. But certainly download that portfolio and see, just have a look at it and see what you can do with it. Because I'm guessing, I think at the end of this term, or this year, academic year, that they're going to be doing more employability skills and stuff, in which case I think I'm going to be in on some of those. And I'd really like to focus a lot more on the portfolios and stuff, because I think it's just going to be so beneficial to you. Like, honestly, I'm one of the people that used to hire, and if I had someone there that was grade A student, A stars everywhere, blah, 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 and I had this student that wasn't so good, but knows what the portfolio is, has attempted to do it, has shown a real interest, has come and had a look around the place, I'm choosing them, not them. You know, so think about, have a look at all the skills that you have done that you can pick out from your jobs, because it doesn't matter where they are. It's transferable skills that we're after. And if you have done much lab work, talk about it. You know, pipetting skills and making up buffers, etc., etc. I mean, I shouldn't say sometimes you can fabricate it, but, you know, needs must.
If it wasn't for Corona, what practicals would we have done for heme?
So for haematology, certainly in final year, you would have done blood grouping, and antibody screens. So literally those cards that I showed you before, that shows you the blood groups. Now, usually those are done automatically on the analyzers, but we would have shown you how to make up a cell preparation of the patient's red cells, and then you would put them into, look at me with me pipette, you put them into the little wells, and you'd add the patient's plasma to them, etc., and spin it down, and there's your results. And interpreting these results is what we would have taught you as well, and just understanding the reasoning behind it, how we use these antibody antigen interactions for testing. But we've managed to do a bit of it. We talked about it, I think, in the practicals. We had some on-site face-to-face practicals, didn't we? But we never actually got to do that, which is so unfortunate. And like, I do really feel for you guys, because it is a difficult time to try and get into the laboratory, simply because of COVID. You know, they're not taking on, lots of places aren't taking on extra staff. But if you don't ask, you don't get. Always ask. Find out who. Look up the website of the hospital or wherever, and find out who's the lab manager. Email them and tell them, you know, I'm currently finishing off my degree in biomedical sciences. I really love haematology and transfusion, blah, blah, blah. And just tell them you're keen and you'd love to come for a look around. And the thing is, they remember that you've emailed them, you know, rather than just leaving it to chance. Be proactive, was what I'd say.
And Charlotte's put as well that she'd be happy to chat with anyone about the registration portfolio too.
Yes, Charlotte's amazing. Sorry, I'm so super proud of you, Charlotte. She's just fantastic. Hopefully someone might be working in the Royal Liverpool Hospital, Charlotte, because there's some jobs coming out for that. But yeah, Charlotte's brilliant. She's happy to help you. That's great. If you want to give me an email, like my email's on there somewhere. It's just emma.moore@mmu.ac.uk. If you want any advice about things, maybe perhaps I can, is there anywhere I could post a link to some of these portfolios and stuff?
We can share them onto people if through email or through social media.
Brilliant. Yeah. Right, well, what I'll do is I will get a copy of the portfolio, like a blank copy, so people can work off it themselves. I'll send the information booklet which tells you all about it and guides you on how to fill it out and stuff, and some other bits and bobs that I can think of, and I'll pass them on to you, Daniela, and then if you can pass them on to others, that'd be great.
Sounds good. Hina said, what is the one thing you would change about your journey, if anything?
Oh, that's a brilliant question. I'd love to have done my MSc earlier. I would. I'd love to have done it earlier, but I was in like a biggest queue ever to get it done. And then I left and went somewhere else and it was facilitated there. But I'd definitely do my MSc earlier. Maybe go on to do a PhD. But now I'm like pushing 40. I'm like, really? Do I want to go and do a PhD now? I'm not entirely sure. But other than that, like I've been so lucky. I really had the best career and I got so much joy from my job and so much satisfaction. And like the relationships that you build with all the other, look at the faces smiling because I'm talking about it. The relationships that you build with other people, whether it's in the same discipline or someone from micro or, you know, it's great. It really is. It's like a big family atmosphere as well. And you learn so much and see so much and experience so much. And like, even some things like some things can be really hard, can be really difficult. Don't get me wrong, not everything's roses. You do work hard as a BMS. And also there are some emotional times, like, for example, I still remember my very first sickle cell patient, and she had a list of antibodies as long as your arm, and she was dead hard to get blood for. And you used to see her bloods coming in all the time, like, oh, there's such and such, oh, it's nice to see that. And then they stopped coming in. I was like, oh, she must be a lot better. And then the results never came in again. And I spoke to one of the nurses and she died of a chest infection, which is a complication of sickle cell. So remember I said sickle cell can cause lots of infarctions and cause organ dysfunction. And it can affect your immunity as well. And so in the spleen, she had lots of splenic infarcts, and so her spleen wasn't working correctly, so therefore her immune system wasn't working correctly, and she ended up dying of a cold. And I've had another patient that, oh, she was just adorable. I mean, I've never met her, couldn't tell you what she looked like, but she had acute myeloid leukemia, and she, when she first got it, she was really, really ill. And she was in and out of intensive care a lot. At one point, she spent 6 months in intensive care. And anyway, she had managed to have a bone marrow transplant. She did really well, and then she relapsed and come back in, and she was due to have another one. And it got just into the new year, and she just really went downhill. So she married her childhood sweetheart in the hospital, and she died the next day. And even, oh, don't cry. I've got a lump in my throat thinking about it. And like all of us were just really moved by it. Like it was so sad because we were used to seeing, like, when her bloods come in, I'd be like, oh, she's doing well, you know, we've got her in today, oh, she's out of ITU, blah, blah, blah. And, you know, we'd ask the haematology nurses when they'd come down to pick up products for them for different patients, how's such and such? And when she came in and we said that we hadn't seen her name in a while, she was like, oh no, she died. And the whole transfusion lab were in tears. And like, even now it still upsets me, thought of it. And other times where I've cried was, I was on call in the lab one night on my own at Liverpool Heart and Chest Hospital, and I came in to start my shift at 5 o'clock. and there was a guy that had been in and out of theatre that morning. He was about 56 or something like that, and he'd been in and out of theatre, and so they were like, he's likely he's going to bleed again, just to let you know. Oh my gosh, he never stopped all night. That guy, I must have issued, I'm not joking here, well over 30 units of blood, as the most I've ever issued to one person in a go. And it was like tag team, me and the HCA, like healthcare assistant. So downstairs was intensive care and POCU and post-op care. And they'd phone up, right, we need more FFP, come on, more FFP. Is the blood ready for that? Yes. And it would be constant, right, I'll give her this product. And she'd run down, they'd phone me and ask me for another one. And it was just like that all night. And he got so much, and like the blood and everything, and the HCA was like, you should see theatre, like there's blood everywhere. And literally at one point she was saying the cardiac specialist was up on the bed with his hand massaging the heart, trying to keep it going and everything. And anyway, we were doing really brilliantly, was well on top of everything. And it's about 5 or 6 in the morning, the HCA had come legging it up again. Have you got this ready? I'm like, yes, here you go. And then the phone went, I'm sorry, the patient's passed away. Oh, like, he'd been bleeding since 10 o'clock. He'd been bleeding on and off all that day. And then from about 9 or 10 p.m, from when I went on shift, he kicked off again, and he was constant. I mean, constant. And so I took the products back off the HCA. She was just like, oh, like this, deflated. And off she went. When she left the lab, I went in the corner and I cried and I cried and I cried and I cried, because you had worked so hard to really do something for that patient, and then he just didn't survive. And it's gone. It is gone sometimes. Like, it's really hard sometimes, because you want the best for your patient, and that's what healthcare is all about. So yeah, you get the great times, but you also get the difficult times. It's hard when you lose a patient, and it's mad to think that I could cry about that now. I couldn't tell you what that man looked like. I don't know what colour hair he had. I don't know what his name is now, you know, but yeah, no, it still affects me. But that's the beauty of healthcare, is it's full of people with massive hearts that really want to do the best for each other. And that's what makes the NHS so remarkable, so incredible. So by all means, I honestly, if you're thinking about going to BMS, do it. Try it. See how you feel. If you don't like it, you can still use that time, that experience you've gained can still take you into other places. What you'll find is biomedical sciences will open a lot of doors for you as well. And there's always chances to progress, always. Oh, gosh, getting all teary.
We've got a few people agreeing that you're PhD material.
Oh, thank you. That's what one of my research things is sepsis. So I'm looking at biomarkers for sepsis, particularly in pediatric cases, because as I said before, like, sepsis is really, really nasty. And that's what you find. A lot of these patients, COVID-19 patients, are actually dying of sepsis. So you can get sepsis from an insect bite. Like my sister, that's what really got me into sepsis research, was my sister got an insect bite on her leg and then nearly died from sepsis. And she's had sepsis twice now. I'm like, for goodness sake, sort yourself out, love. But for adults, there's been loads and loads of research done on it, looking at different biomarkers and stuff, but very little on children. And the main reason being, you can't get ethical approval for children. Like, if you go up to a mother or father and their child is in life and death situation, you want to go, can I have some extra samples, please? They're not really going to do it. And to get ethical approval, you need to have like hardcore evidence to show that, you know, this really is going to do something. So anyway, for my master's project, I looked at children because they can't say, oh, my upper right quadrant is sore, like they're just cry. So I looked into it and I applied some of the biomarkers that they use for adult sepsis. because it's, you know, everyone expects these to be, you know, of course it's going to work for children. No, it doesn't. So some of them I've completely ruled out. I still haven't published that paper yet, but we will. By the end of this, in the next couple of months, we will do it. And what we found is, yes, although children are just mini adults, it doesn't. Their pathophysiology and everything is different. And some of the things that we used for adults, we cannot use for children. And also, interestingly, I had something like nearly 2,000 patients in that study, and about 93% of them received antibiotics and they didn't need it at all. So in an age of antibiotic resistance, now we need to be really careful on how we're doing this. But guidelines state if you suspect sepsis, you do X, Y, and Z. There's like a sepsis bundle, and a part of that is administer high-grade antibiotics, just in case, because the sooner you start on them and it is a bacterial infection, the better, you know, the prognosis for the patient. But what we're tending to find is, like, blood cultures are like the gold standard for sepsis, and it's just rubbish in my opinion, because you get so many false positives. You can get contamination from normal skin flora. If it's virus, it's not going to be picked up on a blood culture. You know, fungal sometimes is difficult to pick up in blood cultures. So you're given and diagnosing sepsis on the basis of a test that's not working correctly. So we need to find these new biomarkers, and this is where biomedical scientists come in. You guys have all the power when it comes to that. You've got the samples, and it's funny, like, because when I was doing my MSc, it was great. And I was like, the university had all the nice fancy instruments and analyzers and all that, but we had the patients. And now I'm on the other side of the coin where I've got the fancy analyzers, but I don't have the patients. But yeah, so there's loads you can get into with biomedical sciences. Honestly, guys, it's just incredible.
Jessica said, do you think it's worth doing a master's straight after a degree, or would lab experience and getting registration be more beneficial first?
In my honest opinion, I would say go and get your experience first. And I'm only saying that from, I mean, it's entirely up to you. Don't take what I say as gospel, like, but for me, when I finished my degree and then I learned so much on the job, like, it made me want to learn more. And I really did so much better in my MSc. Like, I come out with a distinction. Oh, how'd that happen? And it's because I totally grasped the concepts, because it wasn't just on a paper anymore. I knew what it was in the lab. So it was easier to understand. And what you do find a lot of the time is those people that have had that break in the lab or whatever, have been in the lab and then went back and done their MSc, tend to do a lot better than the ones that go straight from it. So for me, I would suggest to try and get into the labs first, and then you can look at doing an MSc on top of that, because you can do as many qualifications in the world as you want, but if you haven't got your foot in the door, you know, it's so yeah, I would say go into the workplace first before doing that. But it depends, maybe it'll suit you better. You know, it's entirely up to yourself. But that's what I find is when you're out there and working on it, it makes things click a lot better, because you understand, because you know how it's used, if you know what I mean.
What are your plans for the future? Everyone kind of ends off.
Well, right, so this is actually going to be hot off the press now. So I was meant to be emigrating to Canada. My husband's already over there. He went over in October, and we were supposed to be gone by last summer, but then this job opportunity come up, and it was like, this was exactly what I wanted to do, was teach. So I stayed here. He went on to Canada. So I'm looking to go till lecture in the universities over there. But as of this weekend, that's all going to change now. So we've husband's coming home and we're not going to Canada now, which is massive. Like, we've been working towards this for like 10 years. So this has just like completely changed everything. So now I'm at the point where this contract with MMU is only temporary. So it finishes in August. I don't want to leave MMU because I love it. I absolutely love it here. But I want to try and carry on with lecturing. But if not, then if I can't get a job in lecturing, I'll go back to my BMS stuff. But I'll go back to the Royal. That's where definitely what would go back to. And I don't know if I'd want to go back to being a senior or rather just like going in and doing my job and going home. I don't know. So I'm not entirely sure. What I really want to do is to carry on with me research and teach, basically. I feel like I've come to the end of my BMS career. I've loved it. It's been amazing. I've had the best time. But I can leave it feeling fulfilled and, you know, ready to put everything into something else now.
Well, I hope you're here next year because then I can have you as a third year lecturer too.
Oh, bless you. So do I. Get on to Nina. Must hire Emma.
I'll send her an email.
But if anybody has any other questions or anything like that, please feel free to email me. I will endeavour to get back to you as soon as I can. But I wish you all the best. And I know it's difficult at the moment, especially with not being on site, on campus. But it's actually, do you know what? I was a little bit jealous of that because whenever I was doing my masters, I couldn't rewind my lecturers. Do you know what I mean? And you've got loads of stuff recorded so you can go back to it. But then it swings and roundabouts. You're missing that contact. And like, honest to goodness, from the heart, we're gutted. Like, but there's nothing we would love more than, especially for me, I'd love to be in the lecture theatre with you guys and like pure bouncing off each other and having good discussions and all of that. But I'd rather you be able to finish your degree surviving than, you know. So just stick with it. I promise you. Like, see, as soon as, like, for that feeling when you hand in your dissertation, my friends, it is the best feeling. It's like this 10-ton lifting weight lifted off you and you're just like, yes. Oh, it's really worthwhile, guys. Honestly, I wish you all the best in everything that you do.
Thank you. Thank you for coming and doing this talk. It's been wonderful.
Oh, thank you so much.
Everyone agrees.
Thank you so much for asking me. But yes, have a lovely evening, everybody, and I'll see you soon.
See you soon.
Thanks, guys. Trust me to have cried as well. I was like, I won't cry this time. I won't.
No, it shows how much you care and how, yeah, it's good. Obviously not a good thing, you're sad, but
yeah, no, it does. These things really do affect you, and it just shows how invested you can get in that job. And don't get me started again. Right, I will go on now. Oh my gosh, 7:10. I told you I'm a chatterbox. Oh my gosh. Thank you so much for this opportunity.
Thank you.
Thank you.
Thank you. Okay,
bye.
Bye.